Hey, what's up, everyone? It's Dr. Glenn Vo, and as I mentioned earlier, I have Dr. Hendrickson, Dr. Whalen. Gentlemen, welcome to the Nifty Thrifty Dentist.
Thank you, Glenn. Glad to be here.
Yep. Yeah, so I am so excited to have you guys on. We had a Facebook Live not too long ago. So many people jumped on, and they were asking questions, and they were asking me all about the course, and I thought, well, you know what? I'll have to bring both of you guys back on here because so many people had questions. But before we get into that, Dr. Whalen, I want to start with you. How did you get into creating a practice that was centered around the removal of third molars? How did you start? And then from there, we'll ask Dr. Hendrickson.
Okay, cool. It's a long story, but I'll give you the short version.
Okay.
Okay, I graduated a long time ago in 1981. I always was interested in surgery. I had my IVC. One of my friends asked me if I could come into his office and help him out. And so I went there, sedated a patient, and I was driving home about 2 o'clock in the afternoon. I think I saw 4 patients. I had a check for $2,500 in my pocket. And I was thinking, gee, I'm not really tired. And I think I'm pretty good at this stuff. And the next thing I know, I was sending out flyers. And at the peak of my mobile practice, I had about 37 offices. And now I've got about 20. So I work 2 weeks a month. I take 3 months off a year. Live in Hawaii, and life is good thanks to third molars.
Yeah, I think I can get used to that schedule, Dr. Whalen. And let me ask you this: how long have you been practicing in that particular style?
Well, I've been doing third molars in my practice for 35 years, but I have limited. I've had the mobile practice where I only do third molars for about 15 years.
Wow, amazing. Okay, so now I'm actually going to ask you, Dr. Hendrickson, how did you get it started in just creating a practice that was centered on just the removal of third molars? And just kind of go through your journey there with us.
I cheated. I bought it. I bought it from an oral surgeon who was ready to retire. He'd been trying to retire for years, and the oral surgeon, believe it or not, the oral surgeon in his area were trying to starve him out. None of them would talk to him or buy it. And I just happened to be in the right place at the right time, and the price was right. And I've always loved doing thirds. I went to Creighton, graduated in 2002, general practice for 7 years before I transitioned. But I remember it was in my hometown. I remember sitting there before I went to dental school and looking at that practice across the parking lot and thinking, gosh, that would be my dream practice. I could own that practice. Never in a million years did I think that would happen. So just kind of situation presented itself, and I took advantage of it. I did do all my own thirds in my private practice for 7 years before I transitioned. I was lucky because at Creighton University when I was there, Dr. Huebner, the director of oral surgery, was really big on GPs doing wisdom teeth, and I did over 120 impactions. So for a lot of guys, think about wisdom, like dental school, that's a lot of impactions for dental school. So I felt like I came out with a decent understanding, at least. Maybe I knew enough to stay out of big trouble, but just enough to get into trouble. And so I went from there. My dad is a dentist, still practices, and he always encouraged me to do wisdom teeth because they were good for patients and good for the bottom line of the practice. And I found that to be the case.
That was so amazing because so many times, when we take different courses and there's an instructor teaching something, it just means a lot when the actual instructor has actually done a lot of that procedure, right? So on that note, Dr. Whalen, how many wisdom teeth extractions are under your belt?
Something like that.
So one more time, Dr. Whalen, you got to froze up there. The number must have been so big that you just for a second. Could you say that one more time? How many wisdom teeth have you extracted?
About 30,000.
Oh, 30,000. Okay. Wow.
Yeah.
30,000. Wow. And Dr. Hendrickson?
I hate to even say, Glenn.
Oh, no, we're going to put you on the spot now.
I don't want people, I don't say this.
Go for it.
I've done about 90,000 wisdom teeth, and people, they are shocked, and they're like, how's that possible? You couldn't do that. And all I can say is I'm being honest. Like I track them. I know how many I've taken out.
Hey, Glenn, can I chime in on that?
Yes, sir.
Okay, well, it was kind of fortuitous how Heath and I met, but I've watched him several times, but one time in particular, I spent the whole day there watching him, and that day he saw more than 30 patients and did over 100 wisdom teeth that day. So if you're doing that many wisdom teeth per day, you can get to the 90,000 number pretty quick. So it's real. It really happens.
And I will say this as a course attendee, course participant, the day before we actually did our own cases, we shadowed both doctors here. And I watched Dr. Hendrickson remove some third molars. And literally, I think you were done in like 20 minutes. And that was including talking to guys like me who kept on pestering you.
I slowed it way down, Glenn. I had to slow it way down to teach.
Yeah, for sure.
So guys, if you're watching right now, if you like what you're hearing, just type in the comment section wisdom, because that just kind of gives a shout out to our instructors right here. But if you have some questions, please feel free to type in the comment sections any kind of questions you may have, and I'll forward that on to Dr. Hendrickson and Dr. Whalen. So the next thing I want to go into, this is always the biggest thing here, is that GPs are thinking, okay, I want to take out wisdom teeth. But I'm really scared of those impacted ones. I want to extract the ones that are erupted, that I can see, and get them out. And what I realized and what I learned is that I was doing it all wrong. I was referring the impacted ones that I thought were really hard and doing the teeth that I thought was easy, but it's the other way around. So Dr. Henderson explained that, because when you said that, I think it just blew all our minds, and we're like, what is this guy talking about? And we didn't realize it until we actually did the cases ourselves.
Yeah, it's a real paradigm shift for doctors, because once we get out of dental school, most of what we hear about wisdom teeth comes from our oral surgeon buddy down the street. And he's encouraging us to send him the impacted wisdom teeth. But when guys come to me, their number one concern, honestly, is inferior alveolar nerve complications caused by the roots of the mandibular third molars. And I'll be really honest with you, if you want to have zero complications, use a good surgical technique and take those teeth out before they have roots. They are more predictable. It is quicker. The patients heal better and faster, and your risk of complications goes way, way, way down. Now, I know it's not what you've been told, but that is the truth. And that's what we teach in the course. It's a huge part of the course is case selection, because we're not saying, hey, take out every wisdom tooth you can. No, it's not about that. It's about picking the ones that are predictable, where you can predict the outcome, give the patient the best service that you as a clinician can provide at your skill level. And yeah, right off the bat, we tell them, hey, look, if you're taking out teeth with roots, those are the hardest teeth. There's nothing like a 35-year-old male with fully erupted wisdom teeth that you're looking in there going, hey, I can see those, I can get those out. Oh gosh, that's famous last words. You want to be taking out the full bony impaction on the 17-year-old that doesn't have any root structure yet. And that's where we focus really our surgical technique and training. You say, John?
And Dr. Whalen, I want you to add on to that.
Okay. I'd be happy to try to do that.
What did you add on to that, Whalen?
Well, all I can say is I totally agree with what he said. He's talking about there. It's an analogy that I use frequently with my patients, is that if you have a little small tree that's only about a foot or two off the ground, it doesn't have much root structure, and you can pull that tree right out of the ground, no problem. But if it's an oak tree that's 100 feet tall, it's got 100 feet of roots, and the roots are the root of the problem. That's what causes the complications.
That's a good way to say.
So get them early before they get roots.
But Glenn, we find that when people come to the course, that's really shocking, because, and you can kind of maybe relate to this, it's that whole concept of the bone removal and managing that part of the case that really kind of freaks a lot of guys out. And with just a little guidance, and you can kind of testify to this, it's not that big of a deal. It goes really well.
And I can attest to that, because actually I was an attendee. I took this course last weekend. And in the beginning, I mean, it was a little kind of intimidating, but what really helped, the way the course was set up, is that we actually were able to observe the first day, watch the flow, and then the next 2 days was hands-on surgery. And we'll talk about the course more in a little bit, but I want to go into something that was really unique that Dr. Hendrickson, you shared with us. And that is the fact that not all the specialists liked the fact that you were taking out their molars.
No, of course they don't. And I understand to a degree. Bottom line is, when it comes to every procedure an oral surgeon does, he does not make any more money per hour doing anything more than wisdom teeth. I mean, it is the number one producing procedure in his practice. So it's a financial issue. And I remember being a GP, and I remember sitting across the table from lunch with my oral surgeon and him telling me, oh yeah, you don't want to get into those full bone impactions, many complications and issues. And I felt like he was just really trying to discourage me. I'll tell you what, be really frank with you. If your oral surgeon would take you into his office, if he would let you observe the removal of 32 full bony impactions and sit down and explain to you the process and the rationale, and then watch over your shoulder while you removed another 8, you wouldn't be referring full bony impactions to him anymore, because it's not rocket science. Okay,
It's
so
not.
that's what he's going to do. This does not mean you're not going to need your oral surgeon or your relationship there. You're still going to send plenty of cases his way. But the ones you can keep in your office that you can do, I mean, why not?
Right. Right. And Dr. Whalen, I want you to talk about that. You gave us, you were really helpful with all the statistics, because a lot of times when we think about impacted wisdom teeth, we think of the worst, horizontal, distal, angular, all those things. And you broke down the percentages. You were saying that the ones that we were learning, that's made up the majority of the type of wisdom teeth. But those really scary ones, Dr. Whalen, talk about that. What's the percentages behind those?
Okay, well, I think that probably one of the more challenging positions is horizontal, and the literature. I actually wrote a book and published by Wiley a couple of years ago, and when I did that, I had to do a lot of research, a lot of articles. So I was spending it's almost a full day. I did a lot of time on the internet doing research, and I learned. And most of the articles that I saw, the horizontals and the distal angular, which are the most difficult positions, they make up the smallest percentage. So about 90% of the wisdom teeth cases that present are going to be either mesioangular or vertical. And then there's another component besides the position, which is depth. So if we're not going too deep and we're picking the mesioangular and the vertical, that's 90% of the cases that you would normally be sending out. And most of the time when you see the roots on the pano or near the nerve, it's either to the buccal or the lingual, so it's superimposition. And if you did a 3D on that, you'd find out that really nowhere near the nerve, even though they might look like it. So the key word, I think, in removing the teeth early, like Heath was saying, is predictability. There's one word. You want to have case selection and then predictability, which is basically the teenagers and maybe a few early 20s, and you're going to be safe.
I love it. And gentlemen, can we take some questions from the audience? There's a few questions now. Can I present you guys with some questions?
Sure.
Okay. And guys, if you like what you're hearing from Dr. Whalen, Dr. Hendrickson, type in the comment section wisdom, show them some love there. And then also please keep the questions coming. So the first one is actually kind of related to something I asked you guys earlier, and that is, can a GP perform third molar extractions at the expert level of an oral surgeon? And Dr. Hendrickson, I'll start with you. And Dr.
We would ask that, can you replace that with any other procedure in dentistry? Can a GP cut a crown with the expert level of a prosthodontist? I mean, doesn't that sound silly to ask that question? Yeah. I mean, when you think about, can you place an implant? I mean, none of us are trained at the OMS level to place implants before we leave dental school. I don't care what your school teaches, but the majority of implants today are being placed by general dentists, because they got the education they needed and the training they needed. I would say, I think John agrees, and John has just developed this course. It's just excellent over the last 10 years. There's just not any good courses out there that teach hands-on third molar removal. It has to be hands-on. And it can't be one of these things where you go and just do a bunch of surgical extractions in the mouth.
That was me.
Yeah, that's different. Those cases are different than removing 4 full bony impactions on a patient. And so it really has to be focused. So that's very niche. We really are for doctors who want to improve their efficiency and their predictability, their profitability with third molar extraction. So yes, I would say absolutely. And if you can't, I mean, I guess, John, you can comment on this, but I would say the same thing, like I said, about implants or about crowns or root canals. Really? What are you going to do? Fillings and cleanings?
Yeah. No, I think that's a
I do. I think you can remove them at the level of an OMS. In fact, you might be surprised. You might even do better. Not all OMSs are created equal.
Dr. Whalen?
Okay. All right. Well, I think that Heath basically nailed it. But I want to address the question from a little different angle. I mean, basically we're thinking, the maxillofacial surgeon did years after dental school. So, wow, how can we compete with that? So let's think about that. They do 6 years. How much of the 6 years do you think they're doing with taking out any tooth in the mouth Okay, when they have Laforts to do, orthodontic surgery, cleft palate surgery, repositioning surgeries, nerve repair. I mean, this is the majority of their education. They're not doing very many third molars, and believe me, they're not any better than you are once you get the fundamentals down. I mean, we're not doing Laforts, we're not doing those OR procedures. We're just helping you remove a tooth, which you're licensed to do.
I love it, and that's so true.
Glenn, I'm fond of saying that general dentists, GPs, do stuff way harder than third molars all the time. If you can, you can restore a DO on number 2. You can do a third molar. We just have bought into this fantasy that the oral surgeons have created to make themselves wealthy, that general dentists shouldn't be extracting the most distal tooth in the mouth. I'm like,
yeah.
I know.
Yeah.
So they control the schools. Honestly, they control the oral surgery programs, and most guys watching probably didn't get a lot of experience removing thirds in dental school. And so you leave feeling inadequate in that area and you send them all off to the oral surgeon. And that's fine. That's why we were trained. That's why there's CE, right? That's why there's opportunities to improve your skills and learn.
I love it. That was a good question, guys. Keep the questions coming.
Yeah, great question.
These are good questions here. And so we have another question here. This one's kind of long, so I'm going to try to summarize this. So we have this doc here who is actually doing deep sedation with a CRNA, and they're the only one in the area doing this besides the OMS office. But he's having a hard time competing with that OMS practice. So he does sedation. They do sedation. He's the only GP that's doing that. He's having a hard time competing there. And what, in your experience, he wants to know what your suggestions are.
Well, this is definitely a question for Heath.
Yeah. I would do the same thing we do in every other area of our practice, and that is we charge less than the OMS. I hate to say this, but for me, part of the niche is charging less. Maybe my overhead's less. I don't know. Maybe make up for it in volume. But the point is, I got patients traveling from all over the country to my practice because they're being charged $3,200, $3,500, $2,800, $4,000, $5,000 for a set of wisdom teeth. And I would just say, look at the price the OMS is charging. I use a CRNA for every case I do. And look at what he's charging. I'd reduce my fee accordingly, just like we do for crowns and root canals. I mean, you notice what the endodontist is charging for root canals lately? My guess is you're not charging the same for a root canal number 8 as the endodontist. I hope you're. I mean, maybe you are. I don't know. It's amazing what they charge. But I would try to compete on price there. I would try to be the go-to guy for families who, when they get that bid for $3,800, they're like, oh, gosh, this is just tooth extraction. And they start looking around and be that guy who's, $2,200 or $1,800. And improve your skill set. Come to our course. Let's cut your time in half on surgery so that you can actually deliver that procedure safely and effectively and productively, and actually do it at a lower price and see more patients. I think you'll be surprised.
And I'll actually add this too, and this is something that both of you gentlemen told me, is that in each of our practices, we have those patients already.
Yeah.
They're there already. They like
You're
you.
a GP with a family practice, you have a ton. And they're listening to you. They're listening to you about when to take them out, how to take them out. You're usually sending them to the other guy.
Yeah. And they want to stay. They want to stay in the practice. That's what you guys have told me, that there's that little kind of gold mine there, right? And then you end up sending that out of your office when you, and even if you're not doing all of them, right? You just do a small percentage to imagine the production. Dr. Whalen.
You're going to do more than a small percentage.
So we got another question here. This is something that I think you guys are very passionate about. So I'm going to put it on here. Straight handpiece or 4 or 5 degree angle high speed? Your recommendation.
Go, John. You can take that one.
Okay. Well, I mean, I guess that's like comparing a Ford Pinto to a Ferrari. I mean, you're not going to find probably very few, if any, oral surgeons in the United States that use a 45 degree handpiece. It doesn't have the torque. And if you were able to look at your handpiece, your 45 degree in slow motion, you could see the burr kind of whipping around. So it's not eccentrically, because that burr is so short. Once you use a straight surgical handpiece, you're going to start at least 45 millimeters. They go all the way up to 70 millimeters. And once they're in the chuck, it turns really concentrically, so it transfers all the energy to the tooth and to the bone. So it's very, very, very efficient. And yes, it takes a little bit of getting used to, but there's no comparison. You got to use a straight surgical handpiece, and that's what we teach in our course. So you get a chance to feel it and experience it in our course. And
Yeah,
it's a game changer.
Yeah, sorry, John. I apologize.
No problem.
It is important to stay out of trouble with thirds, to not have collateral damage. It's important to use straight piece.
And now their follow-up question is, what is your recommendations for surgical burrs?
You want to take that one?
Now you go ahead.
Well, it's interesting because, well, we had one dentist in our course, which was last weekend, who has a lot of experience.
Mm-hmm.
And guess what? He uses 1703L. And then when I met Heath, I asked him what burr he's doing, and guess what? 1703L. So everything is going to be a 1703L, which is basically a fissure burr with a rounded dome tip on it. So it's almost a combination of a round burr and a fissure burr. The cutting surface of that burr is exactly 7.8 millimeters. So if we call it 8 millimeters, that's your ruler. You're wearing magnification. You know that the crown from a third molar goes from the occlusal surface to the CEJ is about 9 or 10 millimeters. When you do your troughing, when you do your sectioning, you're measuring you know that your tip of your 1703L is 8 millimeters. It's a no-brainer.
Yeah.
I would also add there that you're not using a big enough burr typically. GPs use burrs that are way too small. We're not cutting conservative occlusal preps.
And I'll add to that.
Plate, so.
And I'll add to that, and they're being really nice here by not bringing this up. And also, as GPs, our flaps are way too small. They're like, Glenn, dude, you're taking out a tooth, man. You're not trying to baby this. Make that flap bigger. Make that section bigger. All those things. And it's just that's the great thing about the course, right? I mean, there's so many courses out there. And there's some courses, let's go ahead and we're going to transition to talk about different courses. There's so many courses out there. There's some that are taught by really great instructors, but it's not hands-on. There's teaching theory. You're looking at a typodon. You're doing all those things. And it is a whole different level when you're actually doing it and someone's standing there and holding your hand literally and walking you through that. So Dr. Whalen, I want to bring you up because you founded this course. And it's also stateside, one of the few that's stateside. So why did you decide to set up the course in this manner? Obviously, I'm singing the praises about that, but what made you want to set this course up in that way?
Well, I think the biggest thing was I'm self-taught. I mean, even now, as it stands right now, there's very few options, in the United States. And I'm kind of at a stage in my life and career where, I'm not going to turn away the money, but that's not my primary motivation. I have people asking me all the time if I could help them, dentists, I can help them with their molars. And I started out with a very simple observation course, and it just went from it just kept growing because there was so much interest. And that, I just kind of let it evolve. I didn't even really, try that hard to make it happen. But over time, I've been doing it, teaching since 2011. And fortunately, I met few years ago, and as I'm starting to slow down and kind of ride off into the sunset, then Heath is just full of energy, and he's I got about 30 years on him, but it's just evolved. That's all I could say. I mean, I wasn't even really trying. It just happened because there's a need there. People really want to know how to do this, and they don't know how to do it. They don't have it. There's no courses out there.
But something I hear John say at every course is he encourages the attendees to take as many courses as they can. Like get different exposures, see different ways of doing it, different techniques. I think that if you come to our course, I think after that, you'll have a different approach to all the other courses that you take. You'll see what's happening, you'll understand it better, and you'll better be able to use the techniques that they're teaching you. I really do. It's kind of my personal opinion, but we're big on, go to the other courses, get as much experience as you can. We encourage that.
And Dr. Hendrickson, I want to kind of follow up with that question because you have a very successful practice. You have the work-life balance down there, family time, work time, you're very efficient. And so I want to ask you this. It's like, what has kind of motivated you because you're a natural teacher. I mean, when you were teaching us, it was excellent. You really kind of took your time and showed us the ropes and everything. But what motivated you to kind of get into instructing GPs like myself?
Yeah, well, I'm like everybody else. Things become monotonous. 90,000 wisdom teeth. Anytime you do something 90,000 times, there's a little monotony there. But at the same time, I've developed a skill set that I feel like has value. I mean, it really does. I wish that there had been somebody to hold my hand in the beginning and say, hey, you know what, these are the 5 mistakes you're making. And if you just change these 5 things, you'll cut your time in half. Your patients are going to have less trauma, less swelling, less issues. Someone who could really kind of walk me through. So I enjoy teaching. I always have. I've had a dental assisting program. I don't know. I've had taught at a dental assisting school here in Utah and different things. And people say, and I used to even joke about this. This is not entirely true. People say, if you can't do, teach. No, I think for those who get really good at something, it's a natural evolution into teaching because they want to take that skill set and they want to share it. I really do have something to share. I'm not going to be modest about that. It's a real thing that makes a real difference in the way doctors practice.
Right. I love it. And then, that's going to segue right into our next question here. And this doctor's asking, well, if I go to the course, how many teeth can I be expected to remove? And that really depends. That really depends too. So
it depends. But we guarantee 8. We guarantee 8 impacted wisdom teeth that you'll pull and 8 that you'll assist on. So you'll have 16 that you're right there in the mouth. And then between John and I, we take out roughly 32 to 40 impacted wisdom teeth for observation.
So the other thing about, sorry, I get calls quite often from people, and they want to be, they would rather hear from me that they're going to take out 50 third molars. But would you rather, if you're doing 8, that means that you're going to see exactly the same thing 4 times with your hands on. And then if you add in the with your partner, because you work with a partner, now you see exactly the same thing 8 times. Mm-hmm. So you're going to see 8 of the lowers, and you're going to see 8 of the uppers, and it's monotonous because we use 7 steps. So instead of being overwhelming, like what the heck am I going to do next? It's step 1, you flap, then you trough, then you're going to section, then you're going to split, then you're going to remove, then you're going to debride, and then finally the last step, you're going to close it up. And it's kind of a no-brainer when you break it down into little digestible packets. And you see that 8 times. I think that's probably enough. With you actually working in the patient's mouth. And by the way, one other thing that we're probably really proud of is that the course is designed so that there is always going to be an instructor in the room with you 100% of the time. It's not like we leave the room and you're on your own and you have to call one of us. No, we're there to guide you, to look at the x-ray, to talk about the diagnosis, each step, how you're going to proceed, and we're going to be there to help you if you get stuck.
And, I want to add to
rescue you if you need it. I mean, we're there to help out too if you need us to step in.
Yeah, and with that being said, I want to add to that. So here's the thing. I took a course. They knew that I took another course years ago. I went out of the country to take this course, and they said, you're going to extract wisdom teeth, but you're also going to extract some other teeth in there too. What ended up happening is when I went down there, I extracted a lot of teeth, but not that many third molars. And as far as the third molars go, they're all different ones. Yeah. So I never really got good at certain ones, right? And then, of course, picked up some bad habits, which I fixed when I came to this course here. But what's amazing is that they set up exactly the same type of third molar extraction. So you're literally doing the same one over and over. And now I feel pretty confident I do it. Now I can't do it in a minute like Dr. Hendrickson, but I can get it out fairly quickly. And that's the one of the great things there is that they set up these cases that look very similar, and you're not taking out a whole array of different third molars because you're never going to get better.
Exactly. And we're screening, like I think Heath is screening the patients, because we're getting the patients from, the course used to be in California, but now it's in Utah. And Heath is the one that screens the case. So it's not like we're going to just let anybody walk through the door. I mean, those patients are going to be prepared and screened for you. So they match your level of difficulty. He even does a survey. So if you've done no wisdom teeth, or that guy I was talking about that has a lot, we gave him some pretty tough cases.
Yeah.
That's really good. So he got challenged.
We want to stretch it. We want to teach you a case that if you can apply the principles to that case, anything easier than that, full bony, partial bony stuff, you can apply and you can make it work. We want you to
let everyone know this. So it's not, when you go to this course, you're not going out there to have a cup of tea and just hang out. They are actually going to put you to work, number one. And number two, they're not going to put you in a comfortable position. It's going to be a very uncomfortable position. But once you're done and we review the cases afterwards, you feel so good. You felt like you actually accomplished something That's the amazing thing there. So, gentlemen, we got some more questions here. We've been just kind of talking here.
Well, hopefully we didn't torture you too bad, Glenn.
No, you're not. I love talking to these guys. I learned so much. I'm learning so much right now. And actually, you guys have a shout out here. Hey, Dr. Whalen. Hey, Dr. Hendrickson. Thanks again for a great IV sedation course. So I guess they took the IV course. Looking forward to coming to the wisdom teeth course. Okay, yes, fantastic. That's gonna be awesome there. Now we have another question here. I extract thirds with nitrous and sometimes just with local anesthetic. Is it worth taking the course if I don't plan on doing deep sedation?
Oh, absolutely. In fact, maybe even more so. I mean, it's easy to take out a set of teeth and your patient's asleep for an hour and a half. It's a lot more challenging when they're on nitrous or awake, and your technique's going to be way more important. Absolutely. No, these techniques are not just for deep sedation. This is how wisdom teeth are taken out regardless. I mean, this is how it's done. On a patient who's under local anesthetic only or nitrous only, I think your technique is more important, honestly. Patient needs to be more comfortable, needs to be less traumatic, and honestly, it should be quicker. You need to be quicker to keep from causing so much trauma, swelling postoperatively, and just for the sanity of your patient. You don't want them suffering. What do you think? I mean, John, I imagine you agree with that. But.
No, totally. I mean, it's something that the average person that's doing a surgical and impacted tooth, they're not really in sync with the idea that speed is important. I mean, you want to be efficient, but if you take 2 hours to take out a tooth, that person's going to have a heck of a lot more swelling and pain, and it's just going to be nasty compared to somebody that takes the same tooth out in 10 minutes.
Yeah, 100%.
But I like the speed's important, and I kind of want to address, if I may. There was a question earlier about how many impactions are we going to do, or what can we do? And I guess we addressed that from the viewpoint of taking the course. But I would say, with a lot of confidence, that you could probably do 90% of the cases that you've been referring out if you're within the teenage range. So teenage, maybe up to age 25, but for sure teenagers, you've been referring out all these cases that on the x-ray looks like it's close to the nerve, and you can do 90% of those, and we teach you how to select those cases and why you can do it safely. So I hope that whether it's our course or somebody else's course, I hope you start doing third molars, in your practice, because it's great service for your patients. They don't want to leave your practice. They're in your practice because they trust you. If you tell them, hey, I'm going to refer you out to Dr. Wong or something, they don't want to go. So, if you add this to your practice, it's a great revenue stream. You're doing great things for your patients, and it's a win-win. Everybody's happy.
John, Glenn, can I just address that really quick? Because I do not mind talking about the financial end, and I am bothered when people make a big deal that that's like taboo and we shouldn't talk about that. It has to be win-win, patient and doctor. If you just started doing 3 cases a week in your practice, and let's say you're relatively low on the price end, you're $1,500. That's $18,000. Maybe my math's wrong here, but that's around $18,000 a month. And those patients are going to be happy because they're going to be charged $3,000 down the street. Mm-hmm. So one thing I love about my practice is that patients come in and they pay me with a smile because I am doing it for less. They're getting a great service. They're going to have it done anyway. And in you guys, the GPs, they trust you. You're their family dentist. You've been seeing this kid since he was 5 years old. You start taking panels on him at 12. You're taking him every 3 years. You're shepherding those teeth. You're watching right to where they're perfect to remove, and you snag them. And I know that's exactly what the oral surgeon does not want you doing. But I'm telling you, if you get the training for the oral surgeon, it's more about money than it is about the safety of the patient. And of course, we don't want you putting any of your patients in danger or going beyond your scope where you feel comfortable. You don't do zygomatic implants. But maybe you're real comfortable placing implants in the premolar area, upper and lower, in the posterior of the mandible. It doesn't mean you're doing zygomatic implants, right? And wisdom teeth are the same thing. Most of those you can do for your patients safely, effectively, and productively for your practice. And they really are productive. There's no lab bill.
I love it. And gentlemen, can I give you guys some more questions?
Guys, it is a great procedure, and your patients are happy.
Yeah, I love it. And you know what? I told Dr. Hendrickson and Dr. Whalen, say, look, guys, it's going to be just 20 minutes. But I kind of gave them a white lie because I knew a bunch of people on. There's a lot of people watching right now. Guys, if you like what you're hearing right now, type in the comment section wisdom, and then maybe we'll talk about a nifty, thrifty deal. But let's get some more questions. You guys, if you have questions, hurry up and fire them out because these guys have things to do. Okay, but I'm going to throw this question here is. So this doctor's asking, well, you talked about the wisdom teeth that are impacted with no roots. Well, what if I want to learn how to take out wisdom teeth with roots?
Yeah. Go ahead, Heath.
You want me to go ahead? You know,
Yeah.
we talk about it in the course, and the same principles apply to teeth with roots as teeth without roots.
Yeah.
I think the difficulty becomes if you're going to take out teeth with roots, and you've all experienced this, you need to be prepared to either remove the roots or you need to be prepared to leave the roots and deal with the consequences, which are generally positive, but you need to be able to deal with that. Absolutely. And maybe even more encouraging, what we would do is we would say, hey, come to the initial course and do impacted wisdom teeth. And let's talk about those thirds. And then if you want to come back to an advanced course with us, we do offer that to our alumni. We don't offer it on the website. It's more of it's advertised to our alumni. Come back and we'll arrange for some cases like that. There are inherent risks with taking out wisdom teeth with teeth. There just are. And honestly, if it were me, I wouldn't do teeth with roots on older patients without deep sedation. I would do full bony impactions on teenagers all day long without sedation.
Right.
If you're trying to dig roots out of the jaw, it becomes really difficult without some deeper sedation. You can do it. You've been there. I'm sure a lot of you have. I mean, we've done that, but it's a lot more complicated. The further back in the mouth you get, the worse it is. So yeah, we can address that, and we do. We address the technique, but we're not actually showing it live hands-on or having you do those hands-on. We're sticking to full bony impactions on younger patients and working with the basic principles.
And Dr. Whalen, can you add to the fact, because you kind of said this to me too, about the case selection? You know, you were telling me, Glenn, why don't you just look at the cases there? Why put yourself in a situation where you're sweating buckets, okay, when you don't have to? So Dr. Whalen, talk about that, about making sure that you pick the right cases so that you're not just sweating buckets later on.
Okay, sure. Okay, first of all, that we've the predictability part is like what Ruth and I talk about a lot, and we really emphasize that in our course, picking the right patients. But I mean, let's just say this about teeth, the patients that have teeth, impacted wisdom teeth that have roots, it's the word predictability. So you can have a patient that's 35 years old or 40 that has roots, and you can be done with that case in 10 minutes. Yeah. The problem is you might not be 10 minutes, and it might be a complication. So it's not predictable the way it is with the patients that don't have roots. Those are basically 100% of the time you're going to have success, and it's very predictable. The surgical steps that we teach, patient has roots or doesn't have a root. So yeah, we talk about that.
What he said there, sorry, John, you blacked out there. He just said that the surgical principles we teach apply whether they have roots or don't have roots. It's the same.
Exactly. They do. It's the 7 steps, and it's exactly the same. The biggest difference is that if you're doing a patient that has roots, it can be unpredictable. Whereas with the teenagers, it's very predictable. So the age is just one variable. There are many other variables, like are the roots conical? Are the roots divergent? What's the access like in the patient's mouth? Do they have a huge tongue covering over the second molars? Do they have a periodontal ligament on it? Do they have dense bone? Do they have trabeculation? There's many things that we'll teach you in the course, so you can decide, hey, should I do this or should I punt? Punt it down to the oral surgeon, so they can have some fun with it.
Dr. Whalen, kind of like what you told me. Why do you want to do remove a horizontal impacted wisdom tooth on a 45-year-old? Just don't do that to yourself.
Yeah, and it only amounts, the horizontals are only 3%. 97% of your cases are not going to be horizontals.
All right. Everybody wants to learn horizontals. I can't figure out why everybody wants to torture themselves like that. and by the way, horizontal comes up and it's like, here we go. And I will be honest, horizontals go pretty smoothly in our practice, but that's because of time and experience.
Right. They do. And I just, I want to emphasize the age thing and the right time. If you have a tooth that has 1/2 root development, it doesn't make any difference if it's horizontal, distal angular, mesioangular, vertical, or upside down or transverse. It makes no difference. So that basically eliminates the issue of the position. So I mean, even though, you can do older patients for sure, and we can help you decide which ones you can do in a predictable way and not. But the key is not getting in deep where you're there at 5 o'clock in the afternoon, and there's still 10 people in your waiting room, and you're stuck. You're thinking, what am I
get the oral surgeon on the phone to help your patient?
You don't want to be in that situation.
Yeah, absolutely. So let's veer off to the course now. I mean, you guys have so many questions there. We're going to start talking about the course now. If you have any questions about the course, just type it in the comments section here. But let's go over the course. So the course, I want to kind of lay it out because I just took the course, and then you two can just kind of chime in there. But the biggest thing that I asked all the attendees that were with me, I said, what'd you like about the course? Obviously, the instruction is really big, but the fact that it was in the States, I didn't have to dust off my passport and go to Latin America to get this done. I flew to Utah. We got a temporary license very quick. I tried to get one for California for the other course, Dr. Whalen. Remember that? And
Yeah, I do. I remember really well.
Still looking at my stuff. But anyways, I got it from the Utah license. Everyone gets there, and you can practice. You can take care of these patients in the States, in Salt Lake. Great time over there. So it's 3 days. First day is lecture, didactic. Actually, I think there was a little bit of lecture every day. The first day, heavy lecturing, and then we observed Dr. Whalen and Dr. Hendrickson. You got to watch it. You got to see how they did it. And then they said, guys, your turn, right? You go in there, and just like what Dr. Whalen said, there's an instructor there. When I took this other course, and I told him, I had to yell, hey, can I get some help here?
Right.
You just threw me into the deep end, and you're not even here. But they were there really guiding you, and it's 2 days of surgery there. And then you get an autographed book from Dr. Whalen. That's like one of the highlights there.
Well, I want to point out too, Glenn, that this weekend we did $22,000 in donated dentistry to it. And I think that's important. We really are trying to get back these patients that come to the course. Most of them in a position where they cannot afford to have their wisdom teeth out, or they're struggling. That's one of the ways we select them. It's one of the criteria. We're not doing these for the silver spoon kids. These kids, most of them are in a position where they often are Medicaid or welfare on a program with the state, and they can't get approved, and they need to have them out.
I love it. And they were great patients too. Great patients and great families.
Well, and just so you know, Glenn, your patients are doing great. I talked to you.
I was worried. I was going to ask you off the air. I was like, how's my patients doing? All right. So let's take this one question, and then we're going to talk about the specifics of the course. But here's another one. And this doctor's asking, does that mean that you advise to routinely extract wisdom teeth, whether they end up being impacted or not?
You know, here's the funny thing. You kind of have to come down on one side or the other on this argument of prophylactic removal of wisdom teeth. The problem is you don't know if they're going to be impacted until they are. And if it's you, do you really want to wait? I mean, if you're that guy now who has the impacted third molars at 35 and the nerve root is laying on the nerve, and you're faced with the issue, you have to have it removed or have a root canal on a third molar. I mean, ultimately it's coming out. Would you not have rather had that taken out at a time in your life when, number one, you weren't going to miss any work to support your family? The recovery was going to be less than a week. There was zero risk that nerve was involved. There's no crystal ball for this. You can look up all the studies of Amos. There's no way to predictably tell what a third molar is going to be like at age 30, at 17. There's not. No predictable way. The only way you can do that is to remove them prophylactically. So I'm a believer. Obviously, it's my job. Take it with a grain of salt. I do remove third molars. But I remove a ton of third molars differently than John. I see everybody 40 years old, 50 years old, 60 years old. The complications are much more intense. The surgery is much more intense. Every one of those patients, every single one tells me, I wish I had done this when I was a teenager.
Yeah. Oh, yeah. Dr. Whalen, how do you feel about that?
Well, I totally agree with everything that Heath just said. I think that another way to look at this is through the Winters classification and Gregory Pell. So most of you probably aren't familiar with that, but basically it's a classification of impaction. A Winters or Gregory Pell 1 means there's enough room between the second molar and the ramus, and then the 2 there's not enough room, and a 3 most of the wisdom tooth is in the ramus, and you can tell that by the time they're 14 or 15. So that would technically be a prophylactic extraction, but all you got to do is wait till they're 14 or 15, look at the X-ray. I mean, if there's not enough room for eruption, they're going to have a problem.
Yeah,
I mean, that's for 100% for sure. And you want to head that off before they start having pain, before the roots fully develop. But when they're 14 or 15, it's a germectomy usually. But I mean, to me, it's a no-brainer. And I want to add one other thing. There's one other way that you can get kind of an introduction to impactions. There's a guy, Jay Resnick, who is an oral surgeon in LA. He has a website that's called onlineoralsurgery.com.
Yeah.
The last time I checked, it was $500 for a year, and you can look at stuff there on his website. So that's a good place to start. And then, of course, our course, we're biased, but you should be going everywhere to get the information you need. I thought about Jay Resnick when we're talking about the predictability and should you remove all of them? he likes us to say that if the tooth is not, and the key word is easily, if it's not easily cleansable, it should come out. So you can imagine, easily, in the back of the patient's mouth, easily cleansable, that's like maybe 1% that throughout their life is going to be able to easily floss back there and take care of the back of their mouth. So it's going to be most of the people that don't have enough room in their mouth. They need to get them out, even if it's prophylactic. It's better to do it prophylactic when they're younger.
It is, because as they get older, Glenn, even in my practice, you're 30 years old, you come in and you have a set of wisdom teeth that are fitting and they're fine. We don't pull those out.
Oh yeah, we don't do everything. No, the first room in the mouth.
And brushing, baby. You don't want to lose those or have a problem. We all know how many of our patients actually floss every day. How many of them floss distal to the third molar? Let's be realistic.
How many of them actually floss their incisors?
Period.
Well, you know what? I mean, it's so many questions.
And Glenn, in addition, Amos considers impaction a pathology. That is pathological. That is reason for removal. Kind of like John said, or Resnick said, if it's not cleansable, if it's impacted, shouldn't be there. It's not a functioning tooth.
So we got a lot of people watching right now, guys. Again, type in the comment section wisdom if you like what you're hearing. But you know what? I'm gonna kind of ask a little bit more about the course. So Dr. Hendrickson, Dr. Whalen, any of you guys can answer this. So for those who are interested in the course, first of all, what's the easiest way for them to sign up for the course? Would it be going to the website, calling someone, messaging you guys on Facebook? What's the easiest way?
Yeah. So the easiest way would be to go to our website at westernsurgicalandsedation.com. You can choose your course there and you can go ahead and pay and everything, take care of it there. For, your viewers where we might maybe be convinced to, offer a little discount.
Yeah. So let's do that. What's the normal price? Let's start with the
normal price is $8,500. And you can call the number on the website and visit with Hollis. Hollis is our course coordinator, and she can take care of any details out of the ordinary there. So she can take your payment over the phone. She can work with you on payment if you don't want to go through the internet portal. That's totally fine, and she's fantastic. Wish she was here tonight to kind of say hello to people, because she really is great to work with. Glenn, you worked with her for a couple months.
Yeah, absolutely. And she has great taste in food. Great. But you know what, Dr. Hendrickson, Dr. Whalen, you are on the Nifty Thrifty Dentist group in our little video cast here. And so, our doctors here, they're always in this group because they want to get a good deal, right? Who doesn't want a good deal, right? I love good deals. Dr. Hendrickson, Dr. Whalen, you love good deals too. So $8,500 is honestly, to me, I think it's well worth it. This course, you're going to earn that back very fast.
So Glenn, did you pay full price at our course?
I did.
You did.
I did pay full price. So for those of you who are wondering, actually, and the reason being, I'll let you guys know why, is because everyone's talked about this course. I was like, I'm going to go into this like unbiased. And I will tell you what, worth every penny. But you're in the Nifty Thrifty Dentist Facebook group, video cast here. Dr. Henderson, what can you do for our viewers here?
Well, look at it this way. A lot of guys would say, hey, we don't do any discounts because we're going to make you hundreds of thousands of dollars over the course of your career, right? But we understand, and I think John and I are willing to do $1,000 off if they register through, register and say, all they got to say is that they were on the podcast with Glenn at Thrifty Nifty, and that's awesome. We'd be happy to take $1,000 off the course.
Wow. Okay, guys. So you heard it right here. We got it on video. So there's no take backs from Dr. Hendrickson and Dr. Whalen.
Take it back.
Hopefully you're okay with that, Dr. Whalen. I mean, Dr. Hendrickson.
That's
you were just
I don't want to surprise you, John.
No, it's all good. It's all good.
Guys, the normal price is $8,500. Well worth it. Okay, well worth it. 3-day course in the U.S. Hands-on, also observing. And really, there's a lot of learning that goes on afterwards. I mean, we were sitting at dinner and I was I'll say this is kind of a bonus, and maybe your group might not be the same, but I learned so much from Dr. Whalen and Dr. Hendrickson on non-dental things. They have a really great philosophy. I feel really grateful to be able to share my experience, and they share their experiences with me. And so I'm not saying that that's part of the curriculum, but you know what, when you're working that close to each other, you can't help but get to know each other really well. And these guys are really great, very good, really great mentors. So again, the course, normal price, $8,500.
Yep.
Nifty Thrifty price, $1,000 off, $7,500. Guys.
Nice thing about the course being in Utah, Glenn, it's cheaper there. It's cheaper to stay. It's cheaper to fly in.
Everything.
Everything. You can get a license in Utah. We help you get that license. It takes about a week.
Oh yeah. Someone just asked a question. They said, "How do you get a temp license?" Well, you know how you get a temp
It's not a
license?
temporary license. It is a full service license. You can come practice.
It's a 2-year license for me. So literally,
Yeah.
I've been trying to angle coming back to Utah to do some more cases. But how do you get the license? I'll tell you what, Hollis, who is who's helping run this course here, basically, she literally told me, Glenn, do not worry, you're gonna get it in time. I was like, but Hollis, it took me 6 months to get like a letter back from California. I'm still waiting for my license. And she's like, don't worry about it. She sent you a checklist. Sent me a checklist. I did everything on the checklist. 2
How
weeks
many
later.
things were there, Jen? Do you remember how many things there were to do? It's like 3 things.
Yeah, in California,
The cost of the license, I think it's $110.
yeah. I mean, it was very fast, and like I said, guys, you're in the States here. It's in Dr. Hendrickson's office, very comfortable. When I did my other course down in Latin America, we were in a gymnasium with no AC,
Oh no.
and there were some armed guards there, which is kind of cool, I guess.
That's exciting.
But it's like I felt like I was on a mission trip. So if you were going on a mission trip and doing that for that purpose, yes, that's great. But I actually paid to be in the gymnasium with no AC. But
The other thing Glenn will do for doctors is allow them to finance that up to the time of the course. So if they were to sign up for our January course, we divide those payments into how many months are left before the course, and they can pay that over that time period. That's fine. All of our courses for 2020 are up on our website, so they can look forward to next year for CEs. We are AGD certified. Are we PACE certified, John? Can we say that, or just AGD? Did it say that?
It's AGD. Yeah, it's AGD certified. So if they're going towards their fellowship or the mastership, the course units that we give you, they apply towards that goal. And they also help you with your. I mean, it's 3 days. I think we do 30 units because we do talk a lot at dinner and after dinner. So it's like 10 units per day. And that can go towards AGD for sure. We're an AGD provider course.
So 30 units of CE.
and gentlemen, we got people saying, man, this is a great deal. Heck yes, it's a great deal. I mean, it's like I'm shocked here because, like I said, that course is worth every penny. But
Well, John and I we're pretty honest about this. If it doesn't meet your expectation, you don't think it's worth it, we'll give you your money back.
Yeah.
If you're honest,
Nobody's gonna. I don't think an identity CE course is going to make you that deal.
gosh,
and that goes for anyone who's ever taken our course, and we've never had anyone ask for their money back. I'm always this is what I do every day, so I kind of think, is this a big deal or not? And then I see the doctors' faces light up. Like it really is so much fun to watch them see us do the cases and then get in the operator and do them themselves and come out of them and be like, well, I can do that. That's like not no, right? It's like, yeah.
I think I was one of those guys.
You were a little bit, Glenn. It's fun to see your eyes light up.
I already know the answer to this question, but let me just go ahead and put it up, and then I'll let you explain why you're answering it the way it is. So this doctor's asking, can I bring my assistant?
Well, I'll let John address this because he has more experience with actually working physically in the course. But the answer is we don't typically allow assistants. John, do you want to discuss that?
Well, I think the answer is yes, but it's. I'm not sure why you'd want to do that. It's extra expense for you because you're going to have to. We don't pay for your hotel and your airfare to get there, and when you get back, it's easy to communicate to the assistant what you need. I mean, to tell you the truth, these sedated patients, they have a throat pack. They have a Weeder retractor, and your assistant, if they can just basically suction, that's all they get. They don't even have to retract. You're going to be doing most of the retractions.
Someone asked me what my favorite instrument now. It is the Weeder retractor.
Yeah, and most of your viewers don't even know what that is. Yeah, so that's by itself is a real pearl.
Great instrument.
But I just want to say one other thing that is a little bit off of the current topic, but there are a lot of options like down south of the border, and they're on mission trips. So a lot of you like to do that and give back. I can tell you that since the inception of Western Surgical and Sedation, we've done at least $500,000 of free dentistry. So there's no charge for anything. We don't charge for the sedation. We don't charge for the medication that they take home. We don't charge for the procedure. So we're really helping a lot of people every time we do the course. And in our IV sedation course, we usually have somewhere around 50 or 60 patients.
Yeah.
And every one of those would be at least a $2,000 case in the Bay Area, probably closer to 3,000. I mean, we're talking about a lot of money, and we do it all for free, and we happily do that.
Yeah,
so
John,
if you're into,
we got to recalculate that number, because you've given over 12 years so much more than that.
Yeah, absolutely. And you know, I'll answer that doctor's question too about the assistant. I actually learned a lot by assisting myself.
Yeah.
And I mean, I actually got kind of lucky because I went second during the surgeries. And so I actually watched some of the mistakes, and I just came in and I did my trop and split perfect. And I was like, gosh, of course that's easy. And then of course, you know, as other people. Yeah. So you learn so much by watching. You learn so much by watching. You learn so much about, you know, where to place everything, because you're also watching the instructor instructing your partner.
And Glenn, that's if the assistant comes, he or she probably won't be assisting the doctor, because part of the experience for us is the doctors assisting each other and getting that added experience, and we don't want to take that away from another doctor. So
it gets crowded. I mean, we're wearing. I don't think this has been mentioned, but both Heath and I, when we're doing our surgeries, we wear a camera. So there's a camera on our loops, and you know, you can look on a monitor, or you can actually have direct vision in the patient's mouth. But you can imagine having like 10 dentists, 10, 12 dentists. They're in one operatory, or maybe they're sitting out in the, you know, watching on a monitor, but it gets crowded. So if we have another assistant right now that's in there, they're taking the space that a dentist could access if they're not there. So
that's a good point, John.
Yeah, they can come, but you know, they're probably going to get in the way of other dentists learning.
We are putting together, in fact, we'll be doing it this month in September. We're going to be filming from the assistant's perspective and making that available actually on our closed Facebook page to all the alumni and then to future doctors who come. So you can take that video back and you can show it to your staff. And it kind of shows from their perspective, it shows the entire procedure from a distance so they can see what they're doing as far as passing instruments and taking care of the doctor. I think that's helpful. But really, it's like John and Glenn said, if you've got an assistant who's capable and knows how to pass instruments and knows how to suction and squirt water a little bit, you got to pull that back a lot, but a little bit, you'll be fine. Your assistants are going to be fine.
I love it. And, you know, guys, before we log off here, actually, there's a bunch of people who made comments, and I think that you guys would like to see this. So, you know, we have one doctor said, these guys are awesome. They're my favorite instructors.
Are you making these up, Glenn?
I'm not. They're there. You can watch the comments later. Here's another one here. I took this course in February.
Who is that? You know who that is, Glenn?
That is Dr. Bodapati.
Dr. Bodapati.
Oh, hey, John. How you doing?
Yeah, Dr. Bodapati took the course in February, and now they're doing all the wisdom teeth with a lot of confidence. I just wanted to throw that out there because you guys have a lot of.
I want to mention something about her. She made a huge sacrifice to come to the California course. That was the last course we had in San Jose after they changed the law there. And she went the extra mile. It took her like 6 months to get a license. She wanted to be hands-on at that course. It was a nightmare for her. She had to fly to California from she's from the East Coast, like South Carolina or North Carolina or somewhere. And she did, like on 2 occasions, so she could come to the course and be hands-on. And she has really made the best of it. Dr. Bodapati, all the success. Yeah.
Yeah, she was awesome. You know, she was one of our best participants.
Yeah, she's been a great participant. She jumped right in. Yep. Boy, she was yeah.
So, you know, guys, I mean, obviously I had a great time in the course. These guys are legit, but, you know, as you can see, don't take my word for it. Take it from all these people that are chiming in right now. So, you know, before we log off here, Dr. Whalen, I'm going to have you kind of just have the last word here, and then also Dr. Hendrickson right afterwards, and just give you guys the last word here.
Okay. Well, you know, I'll start off with that. You know, I think, I mean, it's just a win-win deal. I mean, you're helping your dentists, your patients that don't want to get referred out, and you know, you're going to add a little bit to your bottom line that it's another revenue stream that you don't currently have that might pay for your kids' college education, or you can take a couple of nice vacations or breaks on it, and it's fun. It's fun taking out wisdom teeth. Fun when you're always successful, one success after another, and you're not having complications. They're not intimidating at all with the right patient selection, and well, I just wish you all the best luck with whatever you're doing in your dental career, and we hope that we meet you in the near future at one of our courses.
Thanks, John. I just want to say a couple of things, Glenn. First, I'm a believer in GPs, and GPs they have a license to practice dentistry, and they should not feel intimidated to do procedures. If they do, they should look to get the education they need to do that procedure competently. And we do that with every group of procedures we have in dentistry, whether it be endo, implants, veneers, 10-unit cases, full arch, full mouth, whatever it is. We've had to go to school beyond dental school to become competent to do that. And I think that this fits right into that category. We should not be intimidated by specialists telling us that we can't do procedures. We just need to be more wise in the procedures that we select to do. And then secondly, I want to say that John and I really do enjoy getting to know the doctors who come to our course. The second night, I think the first night you guys kind of all went out like, just really I think we just went talking or something. But the second night we all had dinner together, and we typically do that. We take each a nice dinner and just socialize. And it just really is an enjoyable experience. You really get to communicate with the other docs, learn from them, and kind of build up a little bit of a camaraderie there as you work together. I find that for me is the most enjoyable part of the course.
I love that. And, I'm gonna. I wanted to give you guys the last word, but I actually have to put this as the last word here, and that is this. This doctor says, "Take all my money right now."
We will just take a little bit, and then you can keep all of it for yourself.
So yes, look, we got the $1,000 discount there, so they're gonna take some money, but I'll tell you what, that small investment, you're gonna make so much more. And with that being said, gentlemen, thank you so much for jumping on. I was so happy to see you guys
Go
again.
to our website, contact us through there, Glenn. That comes right to John, and Hollis. That's who gets those emails, that contact information, those phone numbers. Call us and get a hold of us. We'd love to help you.
I love it. Thank you so much, gentlemen. And thank you, everyone, for watching. We'll see you guys next time.
Thanks, Glenn.